Dr. Robin Friedlander's greatest claim to fame is the fact that we were medical school classmates in Cape Town, South Africa in the 70s. Robin and I literally go back over 40 years. Dr. Friedlander has published 2 books, 17 peer-reviewed articles, 3 book chapters, 2 semi-structured interviews, and I don't know what he does on the side, but he has presented at more than 100 conferences across Canada and internationally. He's the past chair of the Developmental Disabilities section of the Canadian Psychiatric Association and chairs the Planning Committee on the biennial BC Health and Wellbeing in Development Disabilities Conference in Vancouver. Robin founded and is director of the Developmental Disorders Program in the Department of Psychiatry at UBC. Robin, the podium is yours.
So, good morning, everybody, and thanks for coming out on a Sunday, a beautiful Sunday, to hear us. It was a great talk. I just heard it was fantastic what you're doing at your center. I was at medical school with Leon Kadish in Cape Town. Actually, my reputation was that I was always late for the class. And I was once again late today, but I had an excuse. Okay, so I'm going to try and talk about, let's see how this works. Yeah. Why do children with neurodevelopmental disorders have challenging behaviors and what to do about it in half an hour? Let's see.
29 minutes.
29 minutes. All right. So I don't have any commercial interest or conflicts. So I'm going to try and talk about what I mean by neurodevelopmental disorders, a bit about the concept of comorbidity, some of the causes of behavioral problems in these children, and then about 2 innovative interventions which hopefully will be, I think, are quite interesting and exciting. So firstly, what are neurodevelopmental disorders? Well, a lot of people think, and this tends to be the 3 big ones: intellectual disability, or what's still called mental retardation, autism spectrum disorders, and fetal alcohol spectrum disorders. So those are probably the big 3. I hope that's not too faint, that slide, but basically what it shows, the blue circle is intellectual disability, and you can see how autism spectrum disorders in the yellow and fetal alcohol spectrum disorders in the purple overlap with intellectual disability and each other to some extent. The other is other, often genetic disorders and cerebral palsy and so on. So comorbidity is the coexistence of disorders and the sharing of symptoms across disorders. It's really the rule rather than the exception in child psychiatry and developmental medicine, mainly because, you know, our diagnostic systems are not particularly well based in psychopathology, so there's this overlap of what we construct as the entities. And so there's an ongoing debate between the lumpers and the splitters in our field. And you probably find, I don't know who's a lumper in this room and who's a splitter. Splitter over here, yeah, I think I'm more of a lumper. Okay. Anyway, Chris Gilberg, who's a psychiatrist from Sweden, I think is it Sweden? Sweden. He wrote this really interesting little article a couple of years ago he called it Essence. Early symptomatic syndromes eliciting neurodevelopmental clinical examinations. Basically what it is that there are a lot of developmental syndromes that bring kids to pediatric and child development center services. And they include specific language impairment, developmental coordination disorder, learning disabilities, ADHD, oppositional defiant disorder, autism, intellectual disability, FAS, tics. Anyway, it's a variety of problems that bring these kids to see developmental specialists. However, who they go to isn't always, they tend to be referred to many different people. If you have an intellectual disability, you often go to a social worker. If you have specific language impairment, you'll probably go to a speech and language pathologist. If you have epilepsy, you'll go to a child neurologist, and so on. But what's interesting is in the vast majority of cases, these kids may only be seen by one of these or two of these specialities. So the kid who has autism will go to an autism clinic nowadays, because that's certainly in British Columbia. But they may well not see a neurologist, a psychiatrist, nor a educational specialist necessarily. So now I'll give you a child psychiatrist perspective on how I see things. And it's just going back, the reason I mention that is that, I think it is useful to split into different understanding, to split it into different diagnostic groupings like autism and intellectual disability. But we need to recognize that the kids don't read the textbooks, neither do their parents, and the kids tend to present with maybe 5 or 6 different problems. So a child psychiatrist perspective. So this is, a couple of years ago, I did a little brief review of the children that I was seeing. And they mostly had intellectual disabilities. These are 70 unique children, aged, well, some of them weren't children, well, some of them were 24. As the previous speaker alluded, adult physicians often have no interest or expertise in kids with developmental problems, so you end up carrying these kids into adulthood. And of course, they present, these kids don't, what brings them to see the child psychiatrist, by the way, is aggression. The classic by the time I see them, they're usually through that early developmental phase, they're 6 and up. If you hit a teacher, that's a very, very predictable route to my door, because you often get socially excluded from school until you see the doctor. But generally, aggression is huge for a number of reasons in these kids. So in my little survey, aggression was the commonest problem. Kids came to see me. And then there was a variety of problems. They were irritable, sad, few were hearing voices, wandering, bolting, self-injury, not listening, inappropriate sexual behavior, or just touching. I had a kid who just wanted to touch people's heads. And it's kind of fine when you're 3 or 4 or 5, but when you get to 10 or 11, it's not okay anymore. Severe perseveration. I had a kid yesterday, yesterday or Saturday, Friday, who came to see me. She's so, it's part of the brain, her normal brain development, but she is rigid and fixed. Unfortunately, her latest fixation at the age of 16 is on a particular internet site that her mother understandably doesn't want her to access because it's called XChat. And you can imagine XChat is probably not a safe site for a very vulnerable young woman with disability. But the whole conversation was so when can I go back on the site? So, and just in terms of the others, the screaming, shouting, flopping. I got these 2 boys, 6-year-old boys with both of Fragile X syndrome. completely overwhelmed by any transition. So, end of the meeting, time to go, they just flopped, fell on the floor. They would not get up. They were like dead weights. And they're 6 years old. So we've got to do something, because when they get to 8 or 9, we won't be able to pick them up anymore. So taking your clothes off at school is actually a very interesting way to get to see the psychiatrist, and catatonia. All right, so that's what I do. So I guess I'm a behavior specialist. Why are these important? Well, as I mentioned, it's got an effect on the well-being and the social exclusion of the child. These kids often are, I mean, if you touch kids and get in their space, kids are not very tolerant, and they get excluded. It's got a negative impact on the families. Some of these families can't get babysitters because the kids are really challenging. And so it obviously has an effect on their family life. They can't go out to restaurants because the child's behavior is, the child can't sit still in the restaurant. And it's a very high predictor of out-of-home placement. It's also a high predictor that the child will not succeed in the community in general. And often the families will say, you know, I can deal with anything. I can deal with the CP, I can deal with the intellectual disability, but it's the behavior that is the most disabling for them. So the cause of challenging behaviors are communication problems, medical, psychosocial, dual diagnosis, and behavioral phenotypes. And I think I have about 15 minutes to talk about that. Is that about right? All right. So I'll go through this quickly. So this is my second, what's the word? The job I didn't know I had. I'm a detective. I guess I'm a bit like a neonatologist. You only got patients who can't talk back to you, or talk to you, and you've got to work out what's going on. Many of these patients are non-verbal, and so one of the ways you can help them is by augmenting their communication. So older technologies include pictures, buttons which the child can bang to, or push to say what they want. And more recently, iPads have become very popular to help these kids communicate their needs. Medical problems can be a cause of, so you know, one reason kids get angry and aggressive is because they can't communicate their needs. Second reason is that they are distressed, in pain, toothache, whatever. The big three are constipation, reflux, and dental, in my experience. The environment can be a real pain if you don't like noise and crowds, which is what schools are about, if you recall from your days at school. And so it's one of the things we want to try and do is make the environment more suitable for these kids. For the families, the families have the same familial issues as typical families, but I would say a bit more so. And one of the things you see in the older kids with these disabilities is that the kids and the families stay quite enmeshed, and it's not always that healthy. But the reality is that the kids don't pull away from their families and individuate because they just can't. They are realistically too dependent. And we don't have time to address that, but that can be a real issue. So the fourth cause of aggression and behavioral problems is dual diagnosis, which refers to a neurodevelopmental syndrome and a psychiatric disorder. So you may have, in other words, Fragile X syndrome plus anxiety. So Michael Ratter is a child psychiatrist in England. He did a study many years ago on the Isle of Wight, where he studied all the kids on the Isle of Wight. And his group showed that the children who had neurodevelopmental disorders had a 7 times rate of psychiatric disorder compared to the general population of children. In my little study, you can see that many of these kids I saw had a psychiatric diagnosis, and very commonly they had more than one. So autism was the commonest psychiatric disorder, but the kids who just had autism don't come to see me. So they tend to have autism and ADHD and tics, oppositional defiant behavior, and they have problems with sleep. So I don't know, if people here in the audience who work in this field, is that about your experience? Yeah. So, and of course many of these things are really treatable, like sleep is treatable, ADHD is treatable, anxiety is treatable. So you could actually make quite a difference, I think. And it can really transform the quality of life of these children and their families. Actually, I was at a conference, I was at a conference in Toronto last year, and there was a, kind of interesting, there was a fantastic child team supporting this young, I think she was about a 10-year-old girl, who, this was not in Toronto, it was somewhere north of Toronto, and she had all these services for her main problem was running away and aggression. And that she had all these services and a fantastic, everybody worked together, but she wasn't getting better. And then someone had the brainwave, why don't we take her to see the pediatrician? I mean, sounds obvious, they hadn't. The pediatrician saw the child, said the child's got ADHD, treated the ADHD, and everything's working really well now. So, you know, just a good example of how something quite obvious, but it doesn't always get thought of. All right. Okay, so now I get to talk about behavioral phenotypes. So these are interesting phenomenon. Behavioral phenotypes are described by Nyan to describe the outwardly observable behavior so characteristic of children with genetic disorders that its presence suggests the underlying genetic condition. So these are really the, when I was in medical school, I learned about physical phenotypes. So if you have Down syndrome, you would have a certain physical features and maybe congenital heart disease. A behavioral phenotype is a behavioral manifestation of the underlying genetic syndrome. And the classic one that Nyhan described was compulsive self-injury in Lesch-Nyhan disease, this is a particularly bad case I got off the internet. But okay. So now I'm going to tell you about two, what I think are relatively interesting, innovative ideas that come out of this field. So here is a young man who has a genetic syndrome. It's named after him, actually. It's called CK syndrome. CK is nonverbal. He's epileptic. He has long-standing insomnia, hyperactivity, and aggression. And the aggression is refractory to behavioral management and psychotropic medications, remarkably refractory. So one of my colleagues who's a geneticist did a family genogram, and you can see that all of the black are males, the black squares are males. In generations, the males get affected, and the circle with a dot in it are females who are carriers. So what happens is that the males get affected, the females are carriers, and that's classic of X-linked intellectual disability. And in this case, this is a picture of the X chromosome. I've got to warn you, don't ask me any questions about this. I'm getting out of my area of competence. But it's a very richly endowed chromosome. And one of the genes on the X chromosome is the NSDHL gene, which in this particular case, in this child, there's a mutation on the NSDHL gene, and you can see that the cell in the bottom doesn't look as healthy and robust as the normal cell above. And do you remember Professor Kipps, who was our biochemistry, or chempath professor? I think he was chemical pathology, which you all hated. Well, I did. So this is one of his famous pathways, the cholesterol synthesis pathway. And you can, anyway, in red is NSDHL, which is the gene which is mutated and doesn't work in this particular child. So what happens is that there's an abnormality in the synthesis of cholesterol. And so there's less cholesterol available in the brain. And particularly in the developing brain, that's very important because cholesterol is vital to brain development and functioning. So in terms of treating aggression, one option is to try and provide cholesterol supplementation. Just let me go back. There's a model based on Smith-Lemli-Opitz syndrome, which is here. So Smith-Lemli-Opitz syndrome is a genetic syndrome where at the final step before cholesterol is manufactured, and so there is a model based on Smith-Lemli-Opitz syndrome where they've given these kids cholesterol supplementation. Doesn't seem to work that well, probably because cholesterol doesn't cross the blood-brain barrier, and most of the cholesterol in the brain apparently is pretty stable. There's been some studies looking at giving simvastatin with the idea that what's happening is you're getting a buildup of precursors to cholesterol that could be toxic to the brain. And the simvastatin studies, I think, are still, it's unclear what the outcome is. There's studies saying it helps and some saying it doesn't. But it may be that given early on, there may be some innovative treatments here that are worth looking at. It's certainly quite something that most psychiatrists, I don't know how many psychiatrists are in the room. How many of us are there? There are a few of us. I mean, I don't think anyone in psychiatry is talking about cholesterol treatment or when we're talking about treating aggression. So it's an interesting look. And it kind of, I think, shows how children with neurodevelopmental disorders may show real insights into treating adults and typical people. So anyway, the next little issue I wanted to show you is called, this is very interesting. This is mindfulness training. You know mindfulness training? This is a new treatment for anxiety and depression. And this is a study done by a guy called Singh, where he tried to assist individuals with moderate mental retardation to maintain their community placements. So these are adults who had moderate intellectual disability, quite severe uncontrolled aggression, punching, kicking, using objects to hit their staff and their peers, and they really weren't responding to behavioral management strategies and medications, and they were at risk of having to return to the institution. And what he did is he used a meditation on the soles of the feet. How much time do I have? 6 minutes. Oh, okay. So this is the meditation. what you have to do is you have to remember an incident that made you very angry and then stay with the anger. And so you feel angry and you think angry thoughts are flowing through your mind. Let them flow through naturally without restriction. Stay with the anger. So I don't know if you're trying to think of an incident which made you angry recently. And you might notice that you're getting some signs of anger like rapid breathing. What you then do is shift all of your attention to the soles of your feet and move your toes, feel your shoes covering your feet, feel the texture of your socks or your hose, the curve of your arch, the heels of your feet against the back of your shoes. Do not go to sleep. I know it's dark. Anyway, you get into the, so you shift your attention from your anger to the feet and continue breathing naturally. And the idea is to practice this exercise when you're not angry, and then when you get angry, to try and practice, get involved in this exercise. So Singh found that in the adults with moderate intellectual disability or mental retardation, that it had to be modified a little bit. So the one question is the first instruction is cast your mind back to an incident that made you very angry. They couldn't really visualize that episode. So he had to use staff to help the participants recreate the build-up to the actual episode of aggression. That to remind them, remember when Tom was making you angry and he got in your space and you got out of your chair and you wanted to hit him? So they help the client recognize that. So that was a modification. And then the third instruction is to shift all your attention to the soles of your feet. Well, they had some problems with that. And one of the ways they got around that was to put a dot stick on the sole of the participant's feet. And then the participant could feel the sticker and was cued to focus on that. So just two very simple little modifications were all that was needed. All right, which is really interesting. And the aggression went down to 0 and was sustained at follow-up. Now, 3 patients is not a lot, but I think it's really quite an interesting finding. And I think what we're doing now is we are modifying CBT to treat anxiety in adults with intellectual disabilities and children with intellectual disabilities and challenging behaviors who often are anxious and get over-aroused. But I think mindfulness may be an easier technique because there's less verbal stuff. It's very much about visualization. So long as you can visualize, I think it's very promising. So I think that's all I want to say, and thanks everybody very much.